Hi, everybody. Welcome to this very first World Tapering Day webinar. My name is Carol. I will be your host for today. And I'm here with Dr. Tom Cant. Hi there, Tom. Wonderful to have you here.
Lovely to be here. Thank you for inviting me, Carol.
You're going to talk about the open dialogue approach to people experiencing a mental health crisis and the open dialogue system. And to our viewers, please be aware that the information on this webinar is for educational purposes only. So please never consider it to be personal medical advice to you. Well, I think we should get started. Tom, would you please introduce yourself and maybe tell us a bit as well about how you became involved with open dialogue and what it actually is?
Of course, I'd love to, Carol.
Thank you.
Thank you very much. And I'm really pleased to be here, which with what I understand is probably quite a sympathetic community to the perspective and approach that I have had now for 10 years as a consultant psychiatrist in the UK. I started working in crisis teams and inpatient wards, but now work in a community mental health team based in the southwest of England in a small seaside town called Torquay or Torbay. I don't know if anybody's seen Fawlty Towers, but that was also supposed to be set in Torbay. So the same place as that. Hopefully we function a little bit better than this, but so I've been working in the community team now since 2018, and in 2018 I and 12 other members of the community mental health team were trained in the process of peer-supported open dialogue, and that's what I'd like to talk to you about today. So I'm hoping that I will now be able to seamlessly share my screen and presentation, and here we go. Let's give it a go. So will it work? This is my first title screen. So here we are. This is me. There's my email address at the bottom. You're very welcome, anybody, to email me. It sometimes takes me a little while to get back to people. It can take me about a week sometimes to get through emails. But that's me. Now this is, actually Carol gave us this picture. It's lovely, isn't it, of Wellington boots. We might have a chance to talk about the natural world a little bit. We're going to have a bit of a walk through open dialogue. So what is open dialogue and peer-supported open dialogue? A little bit of a difference there, but not too much. And how, so far, how do we know that it could be a helpful thing for people, as Carol describes, in mental distress? So what is peer-supported open dialogue? And on the brackets up there, I've put POD, P-O-D, which I understand in Dutch is actually, it means something quite different. But in the UK, POD means peer-supported open dialogue. It was developed in Finland in 1986. So we're now talking almost 40 years ago. And this development happened as part of one of four programs from the Finnish Health Board. They had very bad outcomes for people suffering psychosis. And consequently, the Health Board thought that it would be useful to develop a number of programs to see if we can improve outcomes. Open dialogue is one of those four. I don't know what the other three were, so that's something you might want to find out for yourself, but open dialogue was felt to be positive. So started in a small seaside town, maybe not that dissimilar to where I work, in northern Finland, and it is fundamentally, it's a socially networked model of crisis mental health care. So at its heart, we are thinking about people and meeting them as part of their social networks. And the way it works as a central clinical offer is with these things we call network meetings. And these are attended by the person of concern, and the person of concern then decides who else they would like to invite. So this might be family, friends, this might be other professionals. It's from mental health care, or maybe from police or social work or probation, or whoever they feel is relevant at that point. So people who can help and people who care. We don't really know exactly how these meetings work in terms of how they give benefit, but there seems to be a developing understanding that there's a shared understanding. So the conversations that happen in these meetings can help everybody in someone's social network understand what is important, what is happening, what things mean in a way. We often, and I'm very bad at this, I think I'll know and assume I know what things mean until we have time to understand this from one another. And it's very common in these meetings that somebody has lived together with somebody for maybe 40 years, and they will say things that I think are really fairly fundamental to the way that they work, and this other person has never heard this before. And it's quite a common thing to happen in these meetings. So there is a sort of power just to the development of meanings, I think. It then puts people in a better position to support one another when they understand where each other are a little bit more. And I think there is also a difference in the way that open dialogue operates, in that it's the person of concern who decides when they want to meet, who they want to meet with, what they want to talk about in these meetings. I don't decide what people talk about, and whether to meet again and what the plan will be. So open dialogue is not anti, in a sense, anything. So it's not anti-medication and it's not anti-psychiatry. In fact, fundamentally, this was developed by psychiatrists. So it's something that it re-levels the hierarchy and power, though. So we're very much giving away the power and expertise that mental health services say they have about what you should do. So people will be in charge of making the plan. So open dialogue is a care planning, these care planning meetings. It's not really a therapy, but it does have some therapeutic potential. Definitely people seem to benefit from being able to be held in a space where they feel safe. They say this quite a lot. They feel this is a safe space to have difficult conversations. And there's a way in which we sit with feelings. So in the same way that trauma-informed care can sometimes be described, you encounter feelings and you remain with them. You don't try and change them or not accept them or move on to something else. We are here now, in the present moment. So it's some therapeutic opportunity there, but not a therapy. So you can be having family therapy at the same time as open dialogue meetings. And that's a very interesting combination. Often with therapy, you'll say, don't have another therapy at the same time. But here we can say we can have these care planning meetings and therapy if you want to. Now, open dialogue it's this clinical offer on one hand, but it's also a way of organizing a service. It would be very difficult to do this clinical offer without a way of organizing a service at the same time. And we'll come on to how this is. In about 2014, some practitioners from the UK, family therapists, psychiatrists, went to Finland, were trained in open dialogue there, came back to the UK and were really excited about this idea of, can we make this possible for people in the UK to have this as their way of receiving mental health care? And consequently, they developed open dialogue into peer-supported open dialogue. And this is on the bottom line there of the slide. They have open dialogue, but added with mindfulness practice that we do in our team meetings together, very much supporting us to understand how we're feeling, be in the present moment as practitioners, and support that growth and understanding for us as individuals. We don't do mindfulness practice in the network meetings with people so much, but on occasions people will ask for that, and so I have done it, but it's not a common thing. And we have peer workers in the team as well. So these are people with lived experience, usually of secondary care mental health services, so psychiatric hospital, crisis team, community team. And these people are employed alongside the workers in the team and bring a great value to the team in terms of their understanding of the nature of, I wonder about the relationship between the system and the human beings, and they can tell us about this in a way that we cannot imagine or understand. So how we are coming across, how we are working, but they can also support individuals who are perhaps not so open to engaging or understanding of what we're trying to do. I hope Carol's going to stop me if there are any pertinent questions coming up. Now, this is our cookbook paper. So this is from 2014. So you can see the date of the title. Now, it took them, there we are, nearly 30 years to write down how to do this. And I think that's a pretty key thing. This was a slowly evolving reflective process to develop this way of working. And in this sort of seminal central paper, both written by professionals within the Open Dialogue Service in Tornio in Finland, but also by academics and family therapist practitioners, Mary Olson, first author in the United States, we get a description of how to organize the service. So that's, in a way, that's the left-hand column there, the core principles, and how to run a network meeting, these clinical meetings, these care planning meetings with people, which is the right-hand side. So I'll just take a little bit of time just to go through some of these and explain perhaps a little bit more about what they mean to me. So on the left, in the core principles, the immediate help principle is that we would hope we are making it possible for people to be responded to when they contact our service as soon as possible. Now, in the UK, as in many Western industrialized countries at the moment, mental health services are not as funded as we would like, and this is a very difficult thing for us. Sometimes we manage it within 48 hours. Usually in Devon, it's nearer a week, but we try to have a meeting as soon as people will want a meeting. When we're meeting people, we are, as I have already said, we are meeting them in the setting of their social network. Very often, people will be meeting us to start off with on their own, because maybe they don't quite trust, they don't understand what this is to start off with. Are we safe? What are we going to talk about? What are we going to do to them? And so coming on their own to start off with, and then slowly feeling safer to invite other people who care and who help. But even when they're on their own with us, we will still ask them, oh, you mentioned your brother, John. What would he say if he was here? So we're still trying to understand and encourage a thinking that has a social networked perspective. The flexibility and mobility principle is very nice to have here. Different services, different communities, different society structures. I personally think open dialogue is, because it can move and change in the way that it flexes around other structures, other services it's meeting, it can be very helpful. And it can be very adapted to different settings. But also, just in terms of the meetings, we would hope that we can meet people at home, or we have network meetings on we have a community based near the beach. So we have meetings on the beach. We do a lot of meetings over video calls now. The pandemic came along. Even the pandemic couldn't stop open dialogue. So we managed to keep going with telephone meetings and with video calls. It's not the same, but it's still certainly some value there. And it has meant that maybe people who are living far apart, we have network meetings with people living in New Zealand, and have one with a man in Sweden where he's a brother of someone, you know, so it is very possible to have these wider networks if you work this way. Responsibility is the next. And now responsibility is it's a big word, and the responsibility here is different. I'm responsible for the process. I'm not responsible for the plan. That, in a sense, unless there is lots of risk and I have to step in and say, oh, I'm just too frightened now, largely the people of concern and their network are responsible for making this plan. I don't make this. I can help contribute to it, but it's not my responsibility to make it. I have a responsibility just to say, what would you like to talk about? And at the end, would you like another meeting? That's it. I don't have any other responsibility in those meetings in terms of developing a plan. I am responsible for making sure that relationships are safe, and that the understanding about the roles and relationships are understood and adhered to, and I'm supporting that I'm responsible for myself in engaging in reflective practice, group supervision. So there are other lines of responsibility here. The next thing is, it feels a very special thing to me, is the psychological continuity. And this is a bit of a challenge in some of our services as they exist at the moment, where we have very broken up care, like a factory production line with, oh, well, we'll do this thing here, and then we give you to another team, and then, oh, well, you fall pregnant, right? You go to another team. Oh, right, you're now in crisis, you go to another team. People don't know people, and this erosion, this damage to relationships is really a powerfully unhelpful thing. So here in Open Dialogue, we try to keep people who know people and relationships really closely supported. And the relationship is a really key central part to an understanding of what makes the service work and what people really welcome about this service. They get to know people, we get to know them, we get to know their family, we get to know their pets. I know a lot of dogs, and so we work like this. So the same facilitators from one meeting to the next as far as possible in our team. Some teams work a little bit differently, have named facilitators. We hope to be there soon, but the amount of work we have has made this difficult in some ways. The next line is tolerance of uncertainty. Now this here is a great thing to have written down, because we in mental health services, we don't like risk. So we try to make sure that nothing happens that we haven't written down, accounted for. We've had some terrible things happen. So we've had root cause analysis and serious untoward incident reviews. And now we've learned some lessons. We'll fill in another form. We'll always ask this person something about, I don't know, as a standard thing on a form, and that will make this safer. Actually, this then leads to some harm, both to the relationship. It also takes the workers away from people because they're doing more and more time on a computer. Russell, another consultant who developed the pod approach, will say that if aliens came to Earth, maybe they would think that mental health workers are IT professionals, because we spend so long sitting in front of a computer writing notes. Actually, if we can say minimum documentation, there is always going to be risk. We are human beings. I mean, we are lumpy, bumpy, and very unpredictable a lot of the time. There will always be some risk. We need to tolerate this. Also, if we don't tolerate risk and tolerate the uncertainty, I will end up trying to control you, and you won't benefit from that, nor will I. And it won't be a very positive or therapeutic experience for anyone. So if I tolerate the uncertainty now, I can still, if we look on the other side of the column, at the bottom, we have being transparent. Now, I can still tell you in these meetings, in a way, I'll tell you how, but in a way, oh, I don't know, this, I mean, I can hear what they say, but I can't see how going swimming 3 times a week is really going to help that much. But they seem really keen on it, and they do say this happened before. So I can tell you that maybe the plan you're making doesn't sound great to my ears, but I mean, that's my judgment. But I can just say I feel worried about that or something, and you can hear that. But I don't have to control you, and I need to tolerate the uncertainty and allow your own expertise and your own wisdom to guide you, and that of your network. And at the bottom here, we've got dialogue and polyphony. So dialogue, there is an inherent power for human beings in just being in dialogue, just talking about stuff. It's amazing, isn't it, to think so much angst and pain and difficulty in the world, but as long as we keep talking, somehow there is a way. Usually there is a way we can find. And when the talking stops, that's often when we find ourselves in more trouble. And polyphony is a description of many voices. So we try and make sure that we have all the voices that need to be present in the conversation. And that extends into a service that we do not talk about people in their absence. So we try as best we can. Sometimes it's necessary where we have lots of risk. We need to think with other professionals quickly in a time we cannot get the other person in, or sometimes actually having the person present, maybe where there's, for instance, domestic abuse, and it's not possible to have there is greater risk there if they're involved. and will increase the anxiety of an abuser who will then become more violent. There are few situations where maybe we don't talk about everything in front of someone, but otherwise no talking about people without them. If you do, it's just gossip. I mean, you don't know, you can't know. They're the only people who really can know about themselves. So there we are. So I'm just going to now say about the right-hand side column here. So we try and have 2 or more therapists, facilitators in a meeting. In any one situation, sometimes only one, but that's only when people are sick or we can't cover them. We involve a family and the network. Often it is family, but not always. We do use some open-ended questions. So these are questions like how, what, why. Oh, can you tell me a little bit more about that? But largely these take only about 30%, 20–30% of what we say, because they are guiding the dialogue. Actually, it's better if we do things on the next line down, we repeat people's utterances. So people might be talking, and for instance, I might hear them say, they said something about dignity. So I just say, dignity to them. And they have some freedom to respond to that, to expand on it or not, or ignore me. But because I heard that word strongly, that I might say that. We try and stay in the present moment, talk about now, talk about what's happening here, what are we struggling with now. We try and, as I said before, with bringing other people's voices in, we use a relational focus, elicit multiple viewpoints. What do other people think about this? Looking at this from all different sides. And we try and talk about what might otherwise be thought of as psychiatric symptoms. So voice hearing, for instance, in a very matter-of-fact way. This is just stuff that happens for people and for human beings. It's quite normal for human beings to hear voices when no one's around. I've heard voices when no one's around. So, and they had a certain meaning for me. So let's talk about that. Kind of, and you then emphasize the words of the client and the stories, not in a sense, I'm not a technician so much here with the psychiatric kind of diagnostic manual where I'm thinking, I've got to fit you in there, but which box do you fit in here? Throughout the meetings, we stop and start at points, and then we will turn to the other facilitator. And when I don't have another facilitator, sometimes I've talked to a cushion, which family think is pretty peculiar, and I say, what struck me? How do I feel when what have I heard so far? Perhaps not so much about what I think they should do. Maybe they've asked me a question, so I can kind of go, okay, well, I'll try and answer that question. But otherwise, largely just what do I feel? What words did they use that struck me? And I find that the reflections are a very useful way where we can put some of that worry if we have about the plan or whatever, we can bring stuff up. In reflection, I've said, I'm so worried now, I'm going to write a recommendation this person comes to hospital. So in a network meeting, I've detained people into psychiatric hospital. So nothing is off the table here. I'm still a psychiatrist, but all this is in my back pocket in a way. It's not so much the front of where I'm being. I try and be transparent, including telling them about me. Some stuff is private, I wouldn't say to people, but a lot of stuff is personal stuff is fine to talk about. Maybe my children. I've just been cutting long wild grass in a corner of the garden this morning, and I was thinking as I was cutting about how a meadow is a very good metaphor some ways for open dialogue and more holistic, natural. I just create the conditions. I don't control it. What grows. And so I was thinking about that before I came in. Tolerate uncertainty. Again, we finished the meeting. I mustn't try and nail everything. Things don't feel finished. I don't really understand what they've said. It's not for me to understand or know, it's for them. So just, would you like another meeting? And that's it. So if you do this, supposedly, in Finland, there was some great follow-up. Now, there is this research, and these figures I'll show you here on this page, have then led to other studies that are still ongoing, and I'm part of a really big randomized controlled trial in the UK at the moment called Odyssey. And Odyssey is looking primarily at relapse. And Odyssey is looking also at relapse time if you offer open dialogue for people with all different mental disorders, not just psychosis. So this, though, is just psychosis, and this is in Finland, and this is a case control study. So this is in a hierarchy of evidence. This is sort of lower down on the way that experiments research is designed. There are only about 50 people in this study, just over 50 people. So it's not big either. It's a problem. And the people who were recording the results, they were some of the team delivering the intervention, I think, I understand. So there is a potential for some bias. So these figures here look amazing, but a lot of criticism has been leveled over the years at these results, but they are amazing enough, and I think they're true. So there we are. But they're amazing enough to mean that people were then willing to spend £3 million on the Odyssey randomized controlled trial in the UK, which is finishing and closing at the end of August next year. And then hopefully we write up and have some results in 2024. So still a little while to go. It's 2 years recruitment, 2 years follow-up, big study, 5 years overall. We're getting toward the end of it, but we're still in it. So, but this is the Finnish response. So mild or no symptoms of psychosis. If you offered open dialogue, so the left-hand column, at 2 years, and this is stable now over 20 years, they're reporting. So now mild and no symptoms about 82% versus treatment as usual, 50%. So treatment as usual were a group of people with psychosis, not in Tornio. They were in a military town in the middle of a wood. So in Finland, but I mean, I don't know, but matched. So they look like the same sort of people. Relapse, so 24% of people have relapsed, but 74% have returned to work or study, while 71% of people with psychosis have relapsed, a lot greater. So hence that big difference. That's why for Odyssey, for our research study in the UK, this is the primary outcome measure. There are some other measures in Odyssey, but relapse is our number one measure. Living disability allowance, so state benefits, much lower proportion, 23 versus 57%. Use of psychiatric medication, which topically today, 35% of people were exposed to antipsychotic medication with all the problems that this medication can have long-term. 35% on average, those 35% in the open dialogue group just had it for 3 days. So just to help for sleep. The treatment as usual group, it's the focus of treatment. So everybody gets it and it's long-term. But in the open dialogue process, you don't prescribe so much. It's not that you don't prescribe at all. And some people arrive and they just want a diagnosis and they want medication. So they have diagnosis and they have medication, you know, they're in charge. So, but here you don't tend to need to prescribe so much. You try not to get your prescription pad out for at least the first 3 meetings, if you can do it, if possible, unless people are really demanding it. So. And hospitalization, in the first 2 years of suffering psychotic illness in Finland, you would be in hospital about 120 days. In the open dialogue group, this was less than 19. So huge saving in terms of harm and experience of loss of autonomy, people being supported to remain in their communities, but also in terms of the cost. It's very expensive to have people in hospital. We can't persuade staff to want to work there, and it's very difficult. So really very positive outcome there. We're also looking at Odyssey at use of medication, and we're also looking at hospitalization. Now in Kent, they set up, so in the southeast of England, I'm in the southwest, but in the southeast, they set up a service a year before ours, and a very inspiring woman called Yasmin Ishak was running this, and she got some money from a UK organisation linked to the NHS called the Health Foundation, and they funded an independent researcher. So not like the figures we've seen before. This wasn't the people delivering the intervention who were collecting the information. This was independent researcher looking at about 80 people, so more people than the time before, and this was an internal evaluation. So these questions are questions that our health inspectors ask. So they're called the Care Quality Commission, and they make sure that hospitals, health services, care homes are providing a good service. And they will come in and ask people using services these questions. So they were asking these questions, and then the Health Foundation researcher asked the same questions of just people having open dialogue for 6 months, and then the people in KMPT, that's the Kent Trust as a whole, and then compared, now we're in the left-hand column, to the whole score in the UK, so well, England, actually. So broadly, the scores out of 10 look much, much better than for open dialogue than the scores for treatment as usual in the same organisation in the southeast of England, but also more nationally. And you can see that, you know, people really felt that they were really listened to. I like this, and they were given enough time to discuss their treatment and their needs. And I feel I don't want to be too trivial, but even if it didn't work, I mean, surely if people are having a better experience, there we are. That would be a benefit anyway, wouldn't it? So I wonder about these figures, but certainly organizations are very focused on money and on the CQC, the Care Quality Commission's report. So this could be a helpful thing for them to know that if you have open dialogue in your service, then your scores might look better. Now, in Kent, they also looked at service usage. And one of the service usage they looked at was how many days in a hospital bed will each person spend. Now, the open dialogue team on the left-hand side, OD team, was compared to the Canterbury and Coast Community Mental Health team in the middle column, and the Maidstone Community Mental Health team on the right-hand side. And the open dialogue team in Kent is a sort of silhouette on the Canterbury and Coast team. So same population. The open dialogue team takes the first 3 referrals every week, and the rest they go to Canterbury and Coast. Maidstone Community Mental Health team is included here because they felt this was their best community mental health team in the organisation. So they compared them as well. And although the numbers of people in each column are obviously very different, you can see the open dialogue team is quite a small team compared to the Canterbury and Coast and Maidstone teams. The number of days in a bed that these people are spending is again about a 1/10. So it's interestingly the same as the slide that we've just seen from Finland. Now this impact has happened for people with all diagnoses. So like Odyssey, this is for people with trauma histories, with anxiety, depression, bipolar disorder, and as well as psychosis. So there we are. And so the average cost per referral at the bottom, they're trying to make this case, come on, this is going to be a much, much more efficient way of running a service because you're not spending big bucks on your beds. You are spending more in your community, but not on your beds. Now, this is an evaluation of the service that I'm working in. And in this evaluation, we've looked at 18 months, and in bold, as we go down, we can see the open dialogue team is on the right-hand side here, and the treatment as usual, TAU, is on the left. Now, I compared the 3,500 people, 3,413 people who'd been under a home treatment team. So they've been under a crisis team in Devon in that period, with 128 people who similarly were ill enough to need crisis care in that time. But they didn't necessarily get crisis care because we offered them open dialogue instead. Okay, now, we offered them open dialogue. Now, if we go to the bottom, right at the bottom of the screen, we offered them open dialogue. Actually, only 67 of them said they'd have meetings. The rest, I don't know what they decided to do, but they didn't want to have meetings. So they wanted to do something else. So they didn't understand what we were offering, or they didn't like the sound of it, and they carried on having treatment as usual. But I've included them here because I think it is important. Don't just include the people who turn up nicely on time. You want to include everybody. People who don't turn up, don't like it, I have some emails from people telling me that open dialogue is a cult. Actually, well, one person is really doesn't like it at all, but there we are. So include everybody, and if you do, it looks like broadly the mean bed occupancy, so the average bed occupancy, now we're halfway down the, and in bold, I'm sorry this table doesn't show up quite so easily, on average, each person offered open dialogue was spending 8.8 days in a hospital bed versus the way that crisis is offered normally 17 days in a bed, so about half. And then going further down the table, and again in bold, you can see how many contacts on average did somebody have in the A&E department. So are they turning up with self-harm or overdose or having tried to hang themselves or something? They're in the A&E department. It looks like this reduces by a third. There is no statistical measure on this, so it might not be significant. My group might not be big enough, but it looks bigger to me. I think the reduction in bed occupancy isn't tenfold here, it's just half, because we're not offering it to everyone. The teams before have everyone, it's just people in crisis, and we're not offering it, and we're including the people who didn't have it, who said no thank you. So that's why. And there we are. Now there's a little bit of information you can get from some of these websites, and I'm very happy for Carol to have these slides and they'll be circulated. And you know, the YouTube film is a lovely one. It's a little bit old now, but it's of the bottom line there of the service in Finland. But there is also another organisation which I haven't included here, and apologies for this, but it's a collaboration of international researchers and people with interest in open dialogue called Hope and Dialogue, all one word, which Carol and I will be able to look up, and I'll circulate via Carol to you later on. So thank you very much. And this last picture is the bottom of my garden. So if anybody, there's the long grass that I've just been cutting. And so if, and lots of brambles that I should be sorting out. But I kind of feel, as I was trying to say a little bit earlier, more and more I kind of see the parallels between the changes to agriculture and the increasing use of chemicals and fertilizers after the Second World War, the specialization, the focus on monoculture, the fragmentation of the way that we've done things. I see that parallel in my own work in psychiatry, and I'm fascinated by this. More and more chemicals, more and more specialist team, and less understanding of this sort of sense of what our essential humanity is. And I really welcome this, and I think that these sort of changes and understandings around agriculture and management of the natural world, I think are very linked to the changes that I feel are happening now in psychiatry. And they are small, and they are just the green shoots at the beginning, but I think they are coming, and it makes me feel very hopeful. So thank you very much, and I do hope this has been understandable and useful.
I think it was, Tom.
Ah, good.
Yes, absolutely. I found it already therapeutical just listening to you.
Oh, that's lovely to hear, Carol.
Exactly.
I can't see if there are any questions or people wanted to say anything, or
Well, you know, I have a couple of questions, and I myself actually was wondering how it is for a psychiatrist to work in open dialogue, because obviously it's a big step from how you used to, or how you would normally arrange your practice, how you would normally work, and then step into the open dialogue approach. What kind of an experience is that for a professional?
It's a wonderful relief, Carol.
Really?
Yeah, because I don't come into the room with somebody and I have 45 minutes to tell them what they should do with 45 years of trauma or their life. I mean, how am I going to know that? So it feels much more democratic. It feels I'm in a place where I can offer some things. As I say, sometimes people just want diagnosis and medication, and that's also fine. But a lot of times I was in a meeting yesterday with a lady who hears voices and has this experience of a character who plagues her, and she's had some difficulties recently. And she was telling me how lovely it was that I was there because I seemed to understand in a way that other people didn't what she was saying. And that just gave her a great relief. And the intensity of the voice and the loneliness and isolation with this experience, she has her husband's in the meeting, also another nurse who's connected to a care home. We were sharing this experience. Some of them hadn't heard about this so much, how intense this experience had been for her recently. She gained a great relief from this. I mean, superb. And then I don't have to give her a medication that's making her fall over or suffer strokes or heart attacks, you know. And well, and it doesn't really work that well anyway. So so that was really lovely. And then actually we discovered in the conversation, there's this, it seems like when your pain is worse, your voice is worse. Do you think, is that true? I'm sort of hearing this, but is this true? And then we kind of got through to this idea, oh, well, actually, if we support the GP to manage your pain a little bit better, then your voice is a bit, no. Anyway, so it's just, it just feels like if I had to go back to work in the old way, one of the team said, if they had to go back working the old way, it's like being a cow in the meadow, being sent back inside the barn. Like it would feel very constraining and not, yeah, we wouldn't feel alive in the same way. So the team love working like, there is a 300% better recruitment and retention in our team than other psychiatric services. So people really like working, you really like working like this. So then you keep this team stays as nobody has ever left the Finnish team in Tornio. Nobody ever resigned from that team. Some have passed away. That's the only way that people have left that team. And that sort of stability of relationships, trusting, feels so important. So having this way to work that is nurturing and supportive is really important.
Yes. And I'm just going to go to another question here. Somebody wants to know how many patients are already on medication when they come to you?
2/3. This is secondary care, mental health services, general adult psychiatry.
Right.
We see people, we had 3 different people ringing up this week to our team saying, I have just tried to hang myself, or I've just taken an overdose. These are people who are really ill. They're really in real danger. So it's not, yeah, this is not, some people think it's a very kind of soft or something approach, or it's something like it's anti-psychiatry. It's not, you can put everything in this house. So it's and it's for everyone, you know, in a sense. Anybody, I don't think there's mental disorder that doesn't work with this so well. Yeah, so, and I think probably it will work better for people who haven't had previous experience of orthodox mental health services, because I think there are people we come across where they have some expectation that they will get this, or that where's the medication, or you tell us what to do. Like, well, I don't know. I don't live in your house. I mean, I can try and come up with some plans with you in time, but we really need to understand this a bit more, but I can't tell you. So that is very common to start with. People will hope we will tell them what to do. People
come to you and they open themselves up to the approach.
Well, you see 67 to 128 in my evaluation. A lot of people really don't really want it, but that's okay, you know, kind of, it's your choice. You come to it when you want to come to it. If things get so dangerous, you have to be I don't know, compelled with the Mental Health Act to that, but otherwise it is your life. You go, you make a choice. I think the normal sort of services, sometimes we end up taking too much. Oddly, we can't provide very much, but we then take too much responsibility. We tell people, you need to be like this, we need to sort of show you how, you know, or whatever, or you engage with us or we discharge you. So here people can come and go when they need. So there's not such a straight line. We don't discharge anyone, and when people need us again, they can come straight back to us, not through their primary care, their family doctor. They don't have to go there, they come straight to us. So we know them, they know us, and that relationship is really key to, and we know their family, and we hear from them, they'll ring us up. So yeah.
Wow. And how many sessions would a client have on average?
We haven't recorded it in England, but in Finland, people had on average 22 in the first year. Mm-hmm. And their service was much better provision to be able to provide perhaps 2 or 3 meetings in the first week, so really intense, and then the space they tended to space out. In our service, the most frequent we can ever really offer meetings is perhaps once a week, maybe once a fortnight. We have some people who are having open dialogue meetings who've had them now for 3 or 4 years with no break. Some people will be doing that. Some people have come, discharged us, they've gone away, come back again, but we haven't recorded this. My sense is they don't get so much in England, in the UK system. Our team is trying to do 2 ways of working at the moment. Soon, we hope, we will just do open dialogue. This will be, you come to our team, you live in Torbay, that's all there is on offer, which some people won't like, but there we are. But we'll have to encounter that. But when we can do that, then we think we will have more availability. But it's interesting, at the end of a meeting, people will say, and we say, would you like another meeting? They'll say, oh, well, how, you're busy. They like, look after us. Well, when can you, so.
Yeah, and another question that I have here, somebody wants to know if you can give an example, so that would probably be a video or something, of how an open dialogue session goes.
Yes, well, I haven't got it here, but yes, you can find it on the internet, on YouTube. So if you type into YouTube, Open Dialogue Network Meeting, Cant has got some videos of network meetings going on. So if you type Cant, K-E-N-T, but you had services in the Netherlands. They were the Dutch were training with us in APOD, in the Association of, but their services have not been funded or supported and started to collapse down now. So it's very sad, because you've got a really good peer system in Netherlands as well, I think.
But it's actually, it is a great pity that the Dutch open dialogue system is no longer working. I was wondering also how widespread is open dialogue if you look across the world?
There are teams and interest in working in this way across in every continent, well, apart from Antarctica. Australia has got some services and interest. Uruguay, Brazil, Spain, Japan, kind of all over the place. There's stuff coming up. In the United States, they had a very good project, a program called the Parachute Project in New York, which was peer-led and delivered. I think that suffered as a consequence of Donald Trump, unfortunately, and I'm not sure it's still running, but they did some good evaluations there. I think the Odyssey trial, the randomized control trial, which is the highest level of evidence, when it reports in 2024, I hope it has an impact around the world, because it's big numbers, good design, really rigorous research methods, and I think people have some confidence then that this will be impactful, but we can only hope.
Yeah, and now I have another question. I find this really interesting. What is the best thing to do if you are a family member or a caregiver or a loved one of a person who has psychiatric problems? I was in contact with several people who were doing that for children, husband, and I noticed that the way they wrote in their emails, how heavy that was for them, how incredibly taxing, and they feel this huge responsibility, of course, and I was really wanting to do something for them as well in the World Tapering Day context, but well, we didn't get around to that, but I'm still thinking maybe one time we should, because what could you say about that? Could you give them some advice? Maybe that's difficult.
I've never been a family member of somebody suffering with a severe mental illness, so it's difficult. I can only wonder about, I work in the team, I work with a lady called Tracy Lang, who is a carer. One of her children has been very poorly, and she's trained in open dialogue. Now, she would be a much better person to talk to about this, but so I'm trying to wonder, what would Tracy say in this sort of situation? I'm trying to think, I think making sure that you are nourished yourself. I mean, it's very difficult, but as a parent, and I have little children, to make sure that I'm not, in a sense, yeah, impoverishing myself. I'm not too thirsty and hungry myself. I can still look after them. It's very important. And then I think Tracy has said to me some things about her interaction with her son that has changed since she has trained in open dialogue, which is a little bit more about just being here and trying to understand this now rather than to fix, and just to be with. And that sort of experience a little bit in a way like a kind of process of mindfulness, of meditation. You're just trying to be, don't say, oh, I shouldn't feel this, or I should feel this, or oh, my mind, or no, this is it. Going away and coming back, going away, that's it. That's being human. So there's a sort of acceptance or something like this. I don't know, but it must be so hard. I cannot imagine. If my children were ill, I wouldn't want to be listening to someone telling me just to accept it. I don't know. I'm not sure how I would feel. So I don't know. It's really hard. I'm sorry to hear that. Good luck.
And well, let's see. I have well, it's not a question, it's a remark, and I like it. It's from the Netherlands, orthopedagogic. I can't even pronounce it. Well, anyway, they work in the same way. They're also therapists in a way. But anyway, they say it's terrific to hear you speak about this. I myself, I feel the same way. It's somehow calming, and how you approach it. You say it's part of life, or you say, I don't know. And maybe that really takes the stinger out of the thing as well, for carers, and maybe for, well, the patient or the client himself, herself. And I was just wondering also before, what kind of feedback do you get from clients?
Oh, well, I've had this one email today telling me that open dialogue's a cult.
Oh, this one, yeah.
But that's not common. It's not common. I mean, it's perhaps I shouldn't say that because it makes it sound like it happens a lot. But no, I think there is sometimes people think, oh, this is because it is a way of sort of thinking and being that people sometimes go, hang on, is this a? I mean, it's not a cult. I mean, it's just there's so many things that make it not a cult. So anyway. But someone told me that I was like an umbrella, which I thought was very nice. And in that, I'm not there to fix the problem. I just create a space out of the rain where they need it to gather together out of the rain. I think that's the sort of idea. A lot of people will say this feels like a safe space to have a difficult kind of conversation. We have an anthropological researcher in the team, or we did have, she's just left and writing up preliminary results. So we have a different study called the Anthropology of Peer-Supported Open Dialogue, looking at what the experiences of people in terms of their networks, the meanings. That this is also coming out very soon. So look out for this article and research coming out, which will answer more of this sort of, what's the experience of both staff and people receiving the approach to have. But it does feel, Carol, it just feels like being a human, kind of the way that people recover from psychosis in developing countries rather than industrialized developed countries has been recognized for a long time as being much better recovery. And people didn't really understand, why is this? We have all the medicines and the hospitals and the experts, but maybe in these developing countries, people are not so isolated. They are living more integration in a community. Yeah. When there is a problem, people can come together to discuss this. And what is interesting is in Finland, where this approach has been working for some time now, a quarter of people have been in these meetings, and the new onset incidence of schizophrenia, whether it exists, but has dropped. So rather than be 1 in 100, it's now 1 in 10,000. So the society, people being able to be with each other in these to counter these problems, that is very healthy. So it feels very hopeful.
It's almost like this whole community feeling that is part of open dialogue, but also of other cultures where people are more part of a community, and that people say to you, you're like a safe place. And so if the community can be that safe place, which it can be and which it is sometimes, maybe we should try to go back to that. And like you said, in Finland, that the situation has changed so much. That's really inspiring, and it gives hope. And you know, this whole World Tapering Day is about medication, getting off medication, the problems with medication, and why is so much medication being prescribed? It's just like a heap of, you know, heap of pills that is not even per se working, and the pills are creating a problem, and actually it's like they're going at it from the wrong end.
I totally agree. Well, people are desperate, aren't they? But
Yeah,
I don't think,
yeah,
I think we've been led to believe not to value our own power, our own,
yeah,
we don't understand this, that we are so powerful to each other. And wow, you know, I have some conflicts within my family. They really upset me when they get resolved. Oh, I feel so, you know, it's so, people are so powerful on people, aren't they? And we should, yeah, we should remember and recognize it. I don't know, but yeah, the medicines thing, I mean, that thing is lots of drive, but no, it's a massive thing.
yeah. And there's also a request. Please show the slide with all the links again,
Oh yes, yes, except I
so
haven't
that
got, we
people
need to,
can.
Carol, we need to put the hope and dialogue link
Oh,
on there.
right. Yes. Here is somebody who wonders if you call testing, or maybe what do you think about biological testing, like testing for vitamin deficiencies, histamine levels, copper and zinc. Do you think that such things can play a role in psychiatric um, trauma?
Really
Beneficial.
something that I've got an awful lot of experience or knowledge of. I mean, but on a very basic level, then yes, certainly there's a big overlap in terms of the way in which sometimes people can present, more particularly with, I've seen more recently with autoimmune encephalitis, and I've been interested in trying to do some early research looking at the way in which immune system changes impact upon nervous systems. We haven't really ever looked at the immune system inside your head so much on a biological level, but I think we perhaps, for me, the more exciting things are less so about that, because they will happen, but I think they're pretty rare. And I think a more profound impact on people is often in the difficulties, the traumatic experiences inflicted upon them by other human beings and human systems, and then the recovery through a social perspective, a social network perspective, rather than a biological one. But it all plays in. I'm trying to think, in an open dialogue meeting, have I kind of, I think we have at times thought about Cushing's, so Addison's and hormone difficulties. I'm talking
Yeah.
to a lady at the moment about the impact of the menopause and getting a greater understanding of this on thyroid
Yes.
expression. And so we do it little bits. It does play a part, but so it's like open dialogue doesn't say no to
No.
anything, but it's just, it doesn't, it's not quite so much its focus.
The word menopause, I've heard that in context also, for instance, with akathisia, with this hypersensitivity to withdrawal symptoms. The level of the symptoms go up. Yes, in for instance, when women have their period or when menopause comes, it might change. And hormones, obviously, they are super powerful. They are, you know, they are the director of the whole physical orchestra, if I may describe it that way. And if the thyroid decides to underperform or overperform, well, it will sweep you away. It will take you up. And yeah, I'm thinking that in care, let's say as another branch to work in on psychological trauma together with open dialogue type therapy could be a branch of the medical profession to look into those kind of things. And maybe one day there will be a specialism that could connect the two. So to see, so it's not only medication, and it's not only talking and being looking at the environment, but looking at something, well, something that connects everything, because in the end it's all one big intertwined thing. the psyche and the body and the surroundings and society.
I hope we do that in our meetings. We think about the biological, psychological, and social, and join it all together. I would love a service that was care planning around open dialogue, and then we have some really well-resourced, trauma-focused, perhaps therapy, but also other avenues of, Bessel van der Kolk's writings about the body keeps the score, the kind of importance of other ways of recovering from trauma. I'm quite interested and excited about the new research going on for psilocybin and hallucinogens and MDMA for trauma. So maybe one day we could have a service where all these different components are kind of able to be accessible and thought about and used where they're placed. Yeah, maybe.
I do think that the open dialogue is really, you're fulfilling such a basic need. It's just warmth and gentleness and listening and being open. And I think that can benefit everybody. And also several things that you mentioned in your talk, I was thinking, well, this sort of viewpoint taken on life, on other people, everybody can benefit from thinking about that from time to time, because we're also caught up in our computer and our television and our car and our job.
Too much.
You forget that we're just only that, the human being is so vulnerable and soft, and we have to be careful with that.
Well, yeah, yes. It's love, isn't it, Carol? I don't know. I'm really scared the horses now, but I think it's love.
Love and care, and opening yourself up to other people. It's so normal, and yet it's so new. Well, so I think,
is it?
Actually, I was going to say we should end on this note, and then maybe someone can send some hearts with the reaction button. I don't know how it works, but I have a factual question here. And the question is, and I'm just, there's a heart.
Heart.
Thank you. Some question here says, oh my God, many.
Carol, you're getting lots of hearts. Get in.
Maybe they're for you, Tom. Maybe they're for you. Here, somebody wants to know, what do you think of Robert Whittaker's work on the Finnish experiments, of which you mentioned in his book, Anatomy of an Epidemic? Well, that's a wonderful book, of course. This person she says, I know the book helped me realize that the current treatment, medicine, in her country, Denmark, it doesn't work for most people on a long-term basis. Well, that's a conclusion I think we have all drawn, haven't we?
Yeah, no, I've not read Robert Whittaker's book, so my apologies. I couldn't comment, but I think just those, just that, the sort of understanding some of those principles that I have come to know about from his writings feel very, I can't question them really. I mean, we're in a really tight corner at the moment, with what we've been led to believe about ourselves and what is available to us and what is asked of us on a daily basis. And we can talk about trying to be present with one another, but my goodness, I don't know about you guys, and but in the UK situation with the price of, I know across Europe and the world, the price of heating, our kind of economy is struggling in a way that means that a lot of our systems and structures for care and support don't work. People are working long hours, many jobs, trying to bring up children, distracted by social media, anxiety. It's quite a sad situation that we're finding ourselves in at the moment, and it's not a surprise that we would therefore then be suffering if we think about what has been happening to us, rather than saying there's anything necessarily wrong with any of us. Kind of first say, wow, my goodness, what has happened to you, before I say what is wrong with you. So
yes, and of course, what I just find such a huge, I was going to say a pity, but maybe I should say what my true opinion is that it's a scandal what the big pharma is doing, and that this is just being allowed to continue by our politicians, and it's creating so much hurt and pain and misery and created a ruin. And what they don't care. And I'm thinking, how is that possible? Why is nobody stepping in and like blowing the whistle and saying, hey, stop? And it's all about the money and the economy, and they don't even care what they do. And that's really sad. And actually, my colleague Pauline, who's also listening, and she tried to get some people from health insurance to participate in a webinar to talk about the reimbursement of tapering medication made to measure. But they won't reimburse it. They'd rather have that people sit with a nail file and trim their tablets. That's like, people driving around in a Mercedes and people who are trying to taper their medication, just wearing one shoe to go that road. And I think it's really sad. Well, yeah, I have to say it. I know they're not going to love me for this.
No.
Well, Tom, I think we've reached the end of our talk. It's been wonderful to have you tell all these things. And I think so. I saw someone who said they would like to have a look at all your slides. And people, I have to say that Tom created new slides, especially for World Tapering Day.
Well, you gave me a help, didn't you? I was lost in my own medical maze, wasn't I, Carol? You helped me out, make them a bit more understandable. So that's really, thank you, and thank you everybody for listening and for being here today. And it feels a great privilege both to be able to talk to you about this and to be part of something that I feel really hopefully can lead us away from that the tyranny that we find ourselves subjected to at the moment. So fingers crossed.
And I'm hoping to invite you another time. I think more attention is paid to this subject, the better it is. I thank everybody in the audience also for joining us. And as I said, the webinar will go on the YouTube channel, which makes it easy to share with other people. And please do so, because the more people it reaches, the better it is.